Good afternoon, everyone. Yes, I changed the title a little bit of my presentation because it was about, the resources, the staff, and pulling it all together. But I think it's incredibly stressful managing the bed situation. Gentleman earlier referred to exactly how stressful that is in the management role. And what experience have I got to be here today to talk to you? Because I feel like I've followed some very eminent statisticians and data people and people who've been managing hospitals. Well, I have managed in the acute environment as well. I've managed a district general hospital and I've managed a hospital in London. I've also, I'm a lean practitioner and I've worked with companies such as Unipart and other consultancies to help managers manage the situation around beds. And I want to share with you just a few areas of work that I've done. There aren't slides, so you're going to have to look at me. And I want to share some examples of the work that I've done and what we did, and what were the outcomes of those. It resonates a lot with what's been said so far this afternoon. It's a terrible situation as a manager when you've got A&E blocked, you've got the chief exec on your back, 4-hour waits up against you, the consultant is screaming from surgery because you know that you're not going to get your routines in. You've got the staff pressures, you've got the relatives, and the feeling is incredibly stressful. And it's at that time that you then start to have the conversations. And my argument is that that's just when you don't need the conversation. And what we've been hearing today is that you actually need this not to be something that you do on top of your business as usual, but actually the conversations about improving the processes and, from what we've heard this afternoon, getting people to think differently across the whole system is what you should be doing all the time. And that's difficult. I worked with some people in the West Country who were divisional directors, and they said that they felt like they were always being pulled into the front line of managing the beds and the stresses and strains of the organisation and not getting on with their normal job. I questioned what their normal job was, quite frankly, because I think actually managing the strains and stresses of that organisation and dealing with the processes around that organisation was exactly what they needed to be doing. And we did do quite a bit of work with that group of hospitals, which I'll come on to in a minute. So I'm just going to go through, because I am going to make sure we stick to time, I'm going to go through 3 examples and pick out from those examples the lessons that we took away, what we actually did, and what the outcomes were. The first example was working in Leicester, and that was actually looking around the beginning of the process, the patients coming into the hospital, and that was taking the decision to admit them via an ambulance, to transfer them via an ambulance to the time that the decision was made to actually admit them to the hospital. Someone said it earlier, I can't remember which of our previous speakers it was, but I do think so often in managing healthcare, we think we know what the solution is. We maybe look at data. I don't think we always look at data. We interpret it quickly, but we actually then get into, right, I know what the solution is and I'm going to solve it. What we did at Leicester was actually really find out what the problem was, and that was a big change for them. And we experimented. and we tried things out a little bit, as you were saying earlier, with the Nuffield experience of trying different things out and involving everyone. Because if you can imagine, in that situation, it wasn't just the acute hospital, it was obviously the ambulance service as well that we were working with. And there's lots of ways of doing that. But I wonder how many of you who work in a hospital environment have actually done what they call in the lean, the whole insight stars things, where you stand and you observe. When we were doing the work at Leicester, we spent 24 hours, 6 days of the week observing. That's an awful lot of resource, but it was incredibly insightful. And it really showed, once you measured that with the data, exactly what was going on. And it highlighted things that people hadn't anticipated. A silly example, but a very powerful example, was the thing about the portering, where they hadn't allocated porters to the department. And you suddenly, by being there and observing throughout a 24-hour period exactly what was happening, you saw just how wasteful that was and how improvements could be made. We did things like look at standardisation, and again through observation, by putting someone who'd not normally in the organisation, and that doesn't have to be an outside person, that can be a person freed up from within the organisation, or indeed, you know, the management executives. They can stand and observe and see exactly what's going on, and there's various tools that can be used. And we came up with the whole thing about standardisation. It was so simple, but it was all about improving that process. They had 5 different cubicles where they were treating the same type of patient, and every single cubicle had a different layout. Just by agreeing a standard working process, a standard approach, a standard layout, the benefits were significant. It meant that everyone knew exactly how to work within the environment. It didn't matter which cubicle they were in. The comments back were, I don't bend down anymore, my back's not killing me, because I'm always bending down to get stuff from the bottom. Very simple processes that improved the process overall. As I say, observation was key. I think the other key thing was looking at communication and clarification, and that was cross organisations, and that was probably the most trickiest thing of all. And there was a limit to the success of that. And those of you who've seen the news this week, you know that there's still issues around that hospital with just the emergency care and coping with that. I think what we concluded, we actually reduced the whole process by 20 minutes. Now, I was going to say on average, but someone told me I should stop saying average earlier this afternoon. But the average time from transfer to admission was reduced by 20 minutes. And that is significant. But I think there was a whole wider learning about it actually can't just be part of the process. Nothing is an island. And we've already heard how everything moves across from beginning to end. So one of the things that was then followed on was actually, if you start at the discharge process and move forward, then you can really look at the whole of the processes and make significant improvements. So that was what we did in Leicester. We also worked with hospitals in Hampshire. And that was a very large piece of work and took a couple of years. And in fact, the Institute of Healthcare Management has got a report coming out at the end of April, which I will do a plug for now, called A Winter's Tale. And one of the person who worked on this piece of work at Hampshire is part of the research in that report. And at that, we were looking much more at, you can't work in isolation, everything needs to be connected, and you have to engage with the clinicians. And that was the key sort of context in which we went into that organisation. And we undertook, I know a lot of you do the process mapping, but we looked at the value add for acute and non-acute across the organisation. We looked at communications to make sure that the clinicians at all levels were totally involved in that. When I first worked with Unipart, who do a lot on healthcare, it was quite interesting to see how transferable some of their processes, not all their processes, but some of their processes were. And the communications cell, I think, is something that transfers incredibly well to the NHS. It gives a structure and process that maybe we shy away from in the NHS, has been my experience. I don't think we take that on board well. We don't like to say you're going to do it in a particular way, but some of the private companies that work with lean, they are very domineering almost in how you work, and you do stand around and it is only 20 minutes and it is very focused. I have to say, working at Hampshire, we sometimes felt a bit silly at the beginning. By the end of the process, the comm cells were the key event. They were attended by everyone. They were led by the clinicians in the end, and they were seen as a key thing. And it was basically looking at people, processes, and continuous improvement. 3 focus areas. And I would say at that point, the other important thing was looking at data and information, because we were bringing in our observations, but we were also looking at the statistics at that point. And so often I've seen examples, and this was Rodney and I started sort of communicating on this when we were talking about this event. I've been to too many meetings in my NHS career where the key occupation seems to be rubbish the data, so that it can be re-looked at and we don't actually have to do anything because we'll get it back next time and it'll have been worked on. I have actually met with an information department in an acute trust, I won't name it, where they told me they were very pleased with the information they provided. And I said, yes, but you know that the data, the actual data items that are going into that information isn't accurate. It was well known. They said, yes, but we really do produce it very well. And there seemed to be that sort of emphasis on, we're going to provide you with lots of information. You may not necessarily know what it is. You may not have necessarily asked for it. And I think within a lean process, you're all the time thinking, what is the one thing I really need to know if I'm going to improve these processes? And that, I think, is key. Again, the work at Hampshire achieved reductions. It identified time when absolutely no value was being added to the patient, which is after all what it's about, or to the process at all. And you could identify that by specialty, by pathway, or however. It was very meaningful information that had been derived from the data and from observation, and the clinicians loved it because it began to give them the chance to actually begin to question what was going on. So that was very important. So reduced the whole process, added value, and actually created some empty beds. And we were so excited when we created the empty beds, we actually went and took a photo of them because people hadn't seen an empty bed. How long ago did anyone here see an empty bed? No, it doesn't happen very often. But I think if we were listening to what Rod was saying earlier, that's maybe where the health service should be going and looking to have the flex up and down. I think the other interesting reflection was actually, and I mentioned earlier, I was at South Bristol Community Hospital earlier this week. Now that's 60-bedded unit. It's a large unit. I think there's some context as to why it was as many beds, which I won't go into here. And it is stepped down, and it is 100% occupancy, and that probably makes it easier to manage. But the processes I observed while I was there were incredibly impressive. They had taken on board the add-on, or which is the lean term for visual identification of status, to the nth degree. It was so easy to see where every patient was, what stage they were at, where the supporting services and therapies were, as far as each individual patient was concerned. So managing in all of this is difficult, and obviously from the conversations we've heard earlier, managing across the STPs, there needs to be much wider debate around the use of beds and what's needed going forward. Managing within the organisation, it has to be continuous. It has to be supported by evidence to support, and that doesn't just mean data. I mean, that we've seen the data is very powerful, but I think hypothesis and observation are key, and I'm not sure that we do that very often. It has to involve everyone, and the comms sellers are as good a way as I've seen of involving everyone, but there are other ways. And I think what we're encouraging managers to do is to ensure that everyone is encouraged to take responsibility. That doesn't mean ducking the issue. It doesn't mean sidetracking that you are ultimately accountable if you're the manager. But unless everyone is involved and responsible and feels enabled to make a difference, which again is what the comm cells are all about, they really don't get involved. They go to work and they live in fear, and they get through the day. So by encouraging everyone to be responsible, from the evidence I've seen both recently and when I was in the NHS and managing acutes, that's got to be one of the key ways forwards. And as I said, celebrating success and taking a photo of an empty bed when you see one. I think I've helped with your time, Roy.
Thank you very much, Jill. Thank you.